Okay, thank you very much, Roshi. So I have the pleasure of chairing the last panel, as I have done in the last few years, and we always get the least people because people want to go and have a coffee, etc. There is also, the panel I was just in is overrunning, so hopefully those people will come down. The final panel, as you see, is related to primary use matters. Now, a small disclaimer, most of you who know me in the context of the EHDS and the discussions I have with you know that I'm primarily busy with secondary use. So this is interesting for me. So, and it relates to the topic I spoke about this morning, about reaching across different worlds and domains. So it's going to be a learning experience for me also, because I'm familiar with the text on primary use, but I don't necessarily have the practical experience of our guests here in traversing it. So, the panel will be a question and answer format. I have a few brief slides, but first I would like to introduce our guests. So first we have, and forgive me for the mispronunciation of your names that will inevitably occur, Catherine Kronicki. Catherine has been with us before in previous years. She is the Secretary General of HL7 Europe. And she is engaged in digital health projects, advancing interoperability and standards for a seamless, productive personal health experience. She is technical coordinator for the XShare project, which I will allow you if you wish to elaborate on further. Then we have Henrique Martins. He is from the University of Lisbon. He has worked for the Ministry of Health in Portugal, where he was responsible for setting the agenda for e-health there. He was president of SPMS, which is Portugal's digital health agency, for 7 years, and he is the member state co-chair of the EU Health Network. He was the coordinator of another project, Expand DH project. I must ask you about these acronyms, they're fantastic. Which is very important in this area, and 2 other EU-funded projects on interoperability. To his left, we have Alberto Zanini. Alberto is the head of international projects and European relations in the Maggiello Group. He has extensive experience in European digital health and identity ecosystems. He played an active role in advancing cross-border healthcare and interoperability under EU initiatives such as My Health at EU. He is deeply engaged with the evolution of the electronic identification solutions, the EID solutions, and the newly established EU digital identity wallet ecosystem. And finally, we have Monica Budvetene. Excuse me very much, I'm very sorry. She is head and coordinator of the Lithuanian National Contact Point for e-health. She is the national expert responsible for the implementation of cross-border e-health services in Lithuania, including e-prescription, patient summary, laboratory data, and also under the My Health at EU framework. She contributes at the European level as a member of the e-health member state expert group, the legal working group, the semantic working group, and the HL7 European Laboratory Semantic Working Group, bridging policy, regulation, and practical implementation. So a range of practical experience that will help us go beyond the bare text of the EHDS. So today we discussed in a call before the panel that we're going to be talking about the format for exchange of data in primary use and why the concept of the format matters and the particularities of it. So why do we need the format? A number of obvious reasons to allow access of health data across borders, to support community continuity of care, to empower patients and professionals, and to build a true European health data ecosystem. And if we're talking about the format, we're talking essentially of a language, of data structures, how information is organized, how things are standardized, and interoperability standards. So how systems from different legacy healthcare structures and database technologies will actually communicate. And we are talking about also, in the next few years, we are in the process of moving not only from the creation of new standards, but from the implementation of those new standards. And this will involve complex navigation of multiple existing systems that we have in our member states at present, and navigating across these differences to allow exchange across Europe. And of course, alignment with other existing EU initiatives that interlock with the use of primary data. So, these are the kind of questions we are going to approach in this panel. Who will define the format? Who is it going to implement it? And always an important question, who will pay for it? And how is it likely to evolve over time? So, that is the end of the slides. And now I'm going to sit and commence with our question and answer session. I would say, please feel free, because you have more practical experience in this area. If my question seems shallow or not probing enough, please feel free to expand. So I would start with Catherine. And a very basic and fundamental question for those of us who are not involved in the area of primary use. Can you explain the idea of data exchange beyond traditional government-to-government models?
Yeah, thank you very much. And thank you for organizing this panel. So if we look at healthcare, healthcare is a multi-stakeholder affair, right? It is delivered by healthcare providers. It is experienced by patients and their families. It is studied by researchers, and it is paid by insurance, private or public, right? Lots of data there. Lots of data that are communicated from one actor to another. And in Europe, we started more than 10 years ago with My Health at EU, where we had the idea that we would exchange patient summaries and e-prescriptions across border. And this was done through national contact points, right? So it was a hub, kind of, on a national level, no matter what the structure of the health system was, that would exchange only these two types of data, patient summaries and e-prescriptions. With EHDS, we raised the bar dramatically because we realized that it is not just those access points that need to be trusted and exchange data. It's a full ecosystem. And actually, we shift also to the person, to the personally directed exchange. And this is extremely important, especially when we are looking at public health and also primary care and secondary care. So shift the focus to the patient. What does this mean? This is the major difference that we see, that we have the patient as the role of the mediator of their health data.
Okay, thank you very much. Next to Alberto, what are the main implementation bottlenecks we have at the moment?
Also from my side, thank you for the invitation. I try to bring the experience or the priorities from the industry standpoint, because my company is involved in the industry landscape. So I'm not bringing today the experience or the standpoint from the member state, but instead from the industry. Main bottlenecks. I would say we should need to improve the awareness about the format, about the HDS, about the actual implementation of the primary use of health data. And I'm saying this because in some member states, I see today a very low awareness of the what is coming next. Also from the vendor's perspective, maybe the awareness is there, but they still need the actual standard format, the actual guidelines to be implemented. This will be provided by the Commission, by the Joint Action HR mainly, by the comitology. So the process is ongoing. But I think the vendors will need very, very soon the final specifications in order to be ready to sell their products domestically and abroad, because this could be the real added value of the format. As a vendor, I will be able to develop a service, a software, and I will be able to sell this service, let's say in Italy, but also in Greece, in Lithuania, in Portugal. This is the real added value. So I would say raise awareness, because I see very few opportunities, and I strongly believe that this symposium, this consortium, could bring added value in terms of awareness, because we have to spread the word about the format thing, about the HDS. We have to create the critical mass in order to allow the vendor to prepare things, to sell things domestically and abroad.
Yeah, to follow up on that question, I have noticed, and I've discussed this with many people, I cannot recall a single incidence of a national politician talking about the EHDS in a public way in the media. And I find this fascinating because it's quite a major intervention in many ways. We don't need to go into all of them now. I actually consider this a good thing because it allowed a more technocratic discussion, but I assume from your answer you would suggest it's a negative thing.
It's a negative thing because I have the perception sometimes that it's still perceived as a thing that will become a reality in the future, but it's not, at least from the industry standpoint. We need to develop things right now. We need to have the final specification of the, let's say, the prescription, patient summary, lab result, etc. right now, in order to be ready to be certified first and then to sell our solution domestically and abroad.
And if it was made more politically, if the profile was raised, you wouldn't fear a kind of a populist input to the situation? Okay. Okay, my next question is for Monique. Do you think the current timetable for implementation is realistic? And if you do not, what do you think is realistic?
Good question. Good question. Actually, you know, it's the time frame. It's that from the European Commission, the message is that every citizen of the Europe should benefit of the primary use of categories, yeah, like e-prescription and patient summary. They should benefit from 2029 and March 26th, something like that. Actually, theoretically, it's possible, yeah, but I think for these countries who are already implemented cross-border services, they can achieve that goal or that idea much faster because the cross-border services, my HELT EU, it's like small example what the HDS want to achieve. Yeah, so I think theoretically it's possible, but the issues will come, and the real reality we will see when we will start to operate, you know, these services between the countries and change the data. Yeah.
Okay, another question for Catherine. What are the risks of over-centralization versus decentralization in format design? And do you think the balance is currently struck?
It's actually a very interesting question. Thank you. So every member state, and in some cases, in some member states, also regions, have their own strategy, regional or national, that relates to digital health. And then there is this umbrella that has come up, which is the HELTDS. So each region and each member state has the challenge that they need to integrate the requirements of the HELTDS, jointly discussed, and agreed, hopefully, Monica, and to the needs and the progress that they make. And not all regions, not all countries are moving in the same speed, right? So from the one side, if we are taking a kind of a centralized approach, we have one format, we totally agree, and we have very high quality data. But then how do you actually accelerate the progress in the regions that are back so that they go up? We have an inherent systemic problem and legal problem in the end. So there is value in centralization, but there is a feasibility question that we also need to address. On the decentralization side, again, we have the ability to engage everyone with their own speed of money, process, and so on. And then we lose control, yeah? Because everybody is implementing or understanding the format in a different way. And what is the clear mistake here? The clear mistake is that you don't have data from 500 million people in the end that can allow you to make good policy decisions. It goes back to secondary use, to improving healthcare at the primary level. So I think the big challenge for all of us, and more for you, Monica, and the people in the member states, is to find this sweet spot between centralization and decentralization that will engage all actors involved, all stakeholders, also in the governance, because the important thing to realize is that the format and the EHDS is not something that is like it will switch on and you are done. We will have a switch in a couple of years, but that would be only the first step. We need to continue. And actually, our recommendation is that we need to start tapping on the value of the HELT for the stakeholders involved. We have to understand the framework that would allow Europe to benefit financially and innovation-wise from the middle ground between centralization and decentralization, which essentially means engaging everyone, all the stakeholders in the governance of EHDS.
Okay, thank you. Now moving to Enrique. What are the main challenges in doing this, in engaging with stakeholders, and what initiatives have you been involved in that might be of benefit to this?
Thank you. Thank you very much for the invitation to participate in this discussion. Well, speaking on, you were asking about the access of the project. We started before Twitter moved to X. Anyway, we find, as Albert was saying, that it's very difficult to wake up even companies for this thing, so they don't realize that in 3 years from now, we are now in April, this is fully implemented. And for example, when we're talking about the data categories, so for everyone's education, so there's 5 data categories that are priority. They're called priority data categories. And 2 of them, the patient summary and the e-prescription, they are earlier, 2 years earlier. Now, just 2 quick answers. I remember I was in a panel in Greece in 2019, and the colleagues from Greece were discussing that there was at the time still some hospitals in Greece with film X-ray. We know that the German colleagues are now in full speed to put e-prescription in Germany, so perhaps they will finish in 2029. But in Finland, there was e-prescription 20 years ago. We celebrated 10 years of e-prescription last year. What I'm trying to say is that we decided, and I don't think people realize, they decided together, because all the MEPs voted. It was voted in the European Parliament next door. We voted that in the same day of the year of 2029, 2031, the entire e-health sector would be synchronized when there is a decalage of about 25 years between some countries in some topics and other countries. So there's a lot of awareness to do. For example, in SHIA, which is a project I'm coordinating, is the Erasmus grant. So we got money from Erasmus to educate. So we're building what we call micro-content learning blocks, so small things of 20 minutes, half an hour. And we are struggling to find good teachers to present the materials. So there's an educational thing. We're talking about thousands of healthcare providers, where if you go now to the average hospital in Belgium, the IT department may know, of course, the national level strategy, the national level formats or whatever, but they don't know about the European format. So in the other project I'm coordinating, I2X, for example, in that case, we have 12 hospitals spread around Europe. And we're going to do 12 implementations of the different domains of the format. But just for people to think, don't forget, I'm saying 13,000 hospitals exist in Europe. HOPE Association told me a few years ago, when we were sort of outlining and the ecosystem. That was a work that we did with Expand the Age, is just outline the ecosystem. And we created different networks, some which are active now. The X Network for Industry, for example, they meet every week. They've done white papers and so on. But for example, we failed completely in the creation of the XNet for patients. It was very difficult. We ended up doing meetings in Portuguese with the patients in Portuguese, in France, in Germany. And this is the last thing I want to say. Maybe people forget that there's about maybe maximum 12 million people, maximum, that speak English in Europe. All the other ones speak their own language, which is not English. They might be able to speak English. But we wrote everything in English. All the EU projects, all the deliverables, all the, not the regulation, because the regulation is translated, but what I'm trying to say is all the soft law, to use the sort of legal perspective, most of our soft law, all the health network guidelines have only been written in English, a language that is spoken by a bunch of Irish, a little few Maltese, and maybe one or two Cypriots that don't know their origin from the Greeks. So what I'm trying to say is, for example, in SHIA, we are now going into the translation. The AI is helping us a lot because the cost would be prohibitively high. We now can make a 5-minute video, we make the script in English, and then with Notebook LM, we make 27 videos in the different languages. So we have tools, and when I said about the I2X, 12 countries, 12 hospitals, you think, well, come on, that's like 0.0 whatever percent. But these are the beacons, these are the front runners. They are implementing this format, even though it's not yet completely written. The implementing acts will only come out next year, and yet we have already started doing technical testing. So it's getting ready, as Alberto was saying. And so all of us have to talk about this, because, and I want to conclude here for now, because I was in the first session and I was in the audience listening into the secondary use and the AI and accessing all the data anonymously. First of all that data, as Catherine was saying, is data that we will put into systems either in a good, well-structured manner or in a dirty, unstructured manner, as we've been doing in the last few years. But the most important thing, and I want to connect with what Catherine said, is that the primary use is much more connected to patient rights than secondary use. So for those in the room that are really fans of the rights part and the legal part, it is the fact that you can download your data from your hospital that is really, really new. When I present the European Health Data Space things in the US or in Asia is even worse, they are amazed at what we wrote in the law. And of course, then they ask, are you going to get ready technically? And I answer them something a little bit more optimistic than now.
Okay, and to follow up on that and to be a bit provocative, is the problem, does it come down to money? Is it because member states are not making sufficient money available, not employing people to drive this process, not making funding available? And without that money, will these education initiatives, is it essentially speaking to a black void if there's no receptive
I mean, I have to say that, for example, I2X is a Digital Europe program, right? It's 50-50 funded. So it was so hard to get a bunch of companies to put in-kind contribution to do what, as Alberto was saying, they would have to do anyway in a few years. Having been at the national level, both ministry and national level head of digital agency, my answer is both money and in-kind. So in the case of Portugal, for example, because it's a smaller country, we built and put in the hospitals interoperability engines. So we built open source MIRT engines, and we rolled out. So there's two ways you can help. You can help with literally with money, which I think is needed. And I think there's a mistake in this regulation that the financial package is not there. I mean, there's some financial package for central activities of the Commission, but there is no money package of the member states. So they commit to something, but they didn't commit any money to it, as if it is going to happen magically. The second thing is really building technology together. This, I think, we have done. I don't know if most people are aware, but what Monique is implementing, and the you showed, Marco Marcello showed the picture early in the morning of the NCPs connecting and sharing data. The engine, the software engine, the MIRT engine also, the Open NCP, the piece of software that runs there was developed by programmers from Italy, at the time Turkey, because it was a project, Luxembourg, Portugal, Finland, and so on. So we can also build tools together and then make them available for the entire implementation. And this lowers the cost. We are not US. We do not have $3.4 trillion, which was what the US put in their market when they started doing this meaningful use initiative. Half of it went all the way to one company only, and they created a mega company, and that's good and bad, and we could discuss. But I think you're right. The final thing on money is procurement. So in next year, the project Catherine is coordinating, we have one task on procurement. Now, when you start talking about procurement, people show up. Companies show up to the seminars. Procurers, a little bit, but they start to show up. So the procurement topic, how do you buy a system and you make sure the requirements are there for interoperability? As long as the procurers, in this case hospitals, are aware they will need to pay a little bit extra for better software because it's compliant with the law, you find a way to move money from one pot to the pot where you need to put it. You need to put money in the companies. There's just no way they're going to put the product up to speed without money. This is the mistake, I would say, the small little mistake that we wrote.
Okay, thank you very much. So I will go back to Monica now. If you want to expand upon what Enrique was saying, perhaps this is a good moment.
I think it's more related with my second question. Maybe it's what key questions and concerns some member states raising about the implementation. So actually member states raising very practical concerns, and many of which are organizational, financial, rather than purely technical, yeah. So they raise the questions, so who will finance the adaptation and long-term maintenance of legacy of hospital information systems, and how to ensure the implementing formats does not, how to ensure that these formats does not slow down the clinical workflows, yeah. So who bears legal responsibility? Is data technically compliant, but clinically context is lost? Who will do that, you know? How to manage change and versioning as formats evolve over time? So who will be responsible for that? Yeah. So actually, in Lithuania, it's like, in our case, in Lithuania, when we implemented the e-prescription, we are live with e-prescription from not 10 years, but it's more than 2 years, yeah, actually. We are live with 8 countries already. And the idea is, to connect more countries. It's 27, up to 27, yeah. That this implementation showed that many of these issues only become visible once, when I told before, that once real services are operational. Yeah, so then you can, you know then what you need to do, or you must now. That's why we are in safe now, in safe, like, safe situation, because we know how things will go on. And if we are speaking about cross-border services, because this is only cross-border services, my health at EU, it's only 2 scenarios, actually. It's A and B. It's A, it's like a country of affiliation. It's a citizen, yeah, and country B, and if you're performing as country B, it's like you dispensing your prescription for foreigners, yeah? And Lithuania, it's actually in this position, in a good position, because we have the centralized system, centralized national system, and for us it's a part. I mean that it's not changed, We are operating as usual. And if we are sending, and if our patients goes to the other countries, so then we are changing. We are the national contact point. We are our national adapter, and we're transforming the data, to other country. So many challenges, many for this. As I told you before, there are many countries who is not in the operational now. They will face a lot of problems, and maybe not problems, but maybe issues, and that's, yeah.
Okay, thank you very much. So we've been talking about some quite heavy technical and bureaucratic stuff so far. So now I'm going to go back to Alberto and go back to some basics. Can you briefly describe what is the core function of the format in this context of primary use, and how it enables cross-border health data exchange? Particularly bearing in mind not all of the participants are active in the area of primary use.
Yeah. I heard a very good definition of a format in a recent webinar, so allow me to quote. The definition was the following. It's not a definition, actually. It's a kind of how to explain the potential of the format. And one colleague said, data without a shared format can travel, but it doesn't speak. I think it's very true. So the format is a common, let's say, a common ground for understanding concepts related to the health data. Also, the dimension on the cross-border, it's important because we have, as we know, 27 member states that will collaborate. And 17 of them are today collaborating, exchanging data, Lithuania among the others. But I think also at the domestic level, at the national level, we are struggling with interoperability problems. I can bring to the audience the experience of Italy, for example. We have 21 different, at least 21 different implementations of EHR systems, one for each region. Of course, our system is federated, so we have, as Lithuania and the other member states, a national contact point able to promote this federation, to allow the connection between the 21 regions when needed. But also at the regional level, we are struggling with issues and challenges in terms of compatibility for a number of reasons. I believe the main reason is the fact that we started with the digitalization of the healthcare sector many years ago. I would say at least 20 years ago. So we have a lot of legacy systems, a lot. And it's very difficult, it's very expensive also to replace the already existing systems. So on one hand, we have to deal with the economic factor of replacing things that are working in real life. On the other hand, we have to be aligned with the format, or we will need to be aligned with the format. Just to say that we usually focus our discussion on the cross-border, which is very true. But in a pan-European vision, the cross-border and the pan-European interoperability should be the same, which means I will need to exchange health data regardless of the domestic setting or the cross-border setting, because I expect the challenges will be the same for a number of reasons. For the legacy systems already in place, especially for the countries that started maybe 20 years ago. And the format will enable this interoperability.
And you're involved in a number of important EU projects in this area. What role are they trying to play in contributing to the development of this format?
Yes, like other colleagues here, I believe all of us we are heavily involved in a number of projects. For example, I will mention a new one. We started last year with a project called My Health and My Hands, which is another 50% funded project. So the partners are also putting their money because they believe in the outcome of the project. We are promoting let's say, a paradigm shift between the citizen and the EHR systems based on the brand new European Digital Identity Wallet. So we are trying to promote an alternative to the government-to-government transactions, which is supported by MyFTU, in which we are connecting to different national contact points, as explained by Monica. We are trying to put the citizen as the center, so the citizen will have the possibility to store in their wallet, in their app, that will be provided by our member states by December 26, by the way. So the deadline is approaching. We will discuss maybe later with detail. So we are promoting this new paradigm in which the citizen is at the center of the solution. He or she is carrying health data and is connecting the different EHR system instead of relying on this government-to-government exchange of data. So we will not be replacing the already existing MyFTU infrastructure. Of course, it is also carved in stone in the HELT, so there's no need to replace something which is operational and working. But we are aiming to create a different way of exchanging data, putting the citizen and the patient at the center. This is a good example of, let's say, European-funded, co-funded project in which we are working on. We are also working on the medical imaging, for example, with some projects. One of them is called the Screen C. Actually, it's a product, so it's, let's say, more than a project because it started like a European-funded project, and now is a product that we propose to the market, in which we promote the screening campaign in order to invite people to have some screenings in case of need. And also for the secondary use of data, we are very active in the so-called cognitive training, especially for the elderly. This has little to do with the primary use of F data, but the field rules, let's say, between all the three projects is that all of them started with a European-funded initiative, and now is becoming, all of them are becoming something more. And two of them a product, actually.
Okay, now to Catherine. I see a nice question we discussed in our meeting, and it is about the extent to which the format should act as a bridge between primary and secondary use, and it's about the value of primary use to secondary use. And I might add a kind of provocative statement to that. Do you think that too much has been talked about the cross-border element in primary use as a flagship? Because we were talking about the lack of English speakers in Europe. We all know the reality is that there are far fewer people who ever use cross-border care in Europe. This is a real tiny minority. So do you think this should be seen as the real important benefit towards standardization in primary use?
I'd like to speak also about my project, or one of my projects that may be the flagship that we are doing, which is called XAIR. And what we try to do there is essentially connect primary use with secondary use and clinical research. I know some of you may consider that clinical research and secondary use or population health are the same thing, but actually they're not. Because we see use cases that are very much grounded in primary use, which secondary use people consider secondary use. Let me give you an example. I am a patient, and I was just diagnosed with this obscure disease that I went up to ChatGPT to find out about. Now, I need to see if there are any novel therapies, any things that I can do to save my life or become functional again soon or avoid delayed. How do I do that? I try to find clinical trials that match my data, that I am eligible for, find which hospital hosts them, go there. I don't care if it is in my country. I can do Belgium. I can do wherever in the world because I want to be healthy again soon. So is that primary use or secondary use? Secondary. Some people, if you take the government side, it's secondary use. If you take the citizen side, it is primary use. And that's what XR is about. No, not yet. Not yet. I haven't finished my...
We call it circular use in our new project,
Okay.
you and me.
All right. So in XR, we are actually identifying something that needs to happen, and that is a culture shift. We all actually discussed this earlier, and you probably could comment on that. Clinicians have the need to do less with technology. And the format needs to serve that goal. Spend less time on entering data. Enter once, high quality, quickly. How do you do that? Physicians care about workflow. They want to be able to invest their time wisely on the patients. That's what the format needs to do. And that's not only a technical question. It's also a legal question, it's an organizational question, and so on. If you take the patient side, then patients need to understand, especially think about aging patients. They need to understand what this data is about. We are talking in XR about this yellow button that you press. So this is an action, and you get your data in a format that you can introduce to another system, maybe an AI, and you can get good answers, yeah? But this has to be done for everyone, in everyone's language. So we are talking about a major shift. I actually talked about it last time I was here, where we are talking about a data economy. And how does this translate to your question or personal, primary and secondary use? It means that EHDS needs to look at low-hanging fruits, things that can bring value, things that can be quantified so that the stakeholders believe that this is relevant to them. It's not a cost they have to pay, but it's an investment that they will get money back. They will have their people healthier sooner. And that's not a question of primary use. It's a question of primary and secondary use. It's a question of public health as much as it is a question of pathways and so on. And I can tell you one concrete example that I'm very passionate about, and please reach out to me. So we are in XR now proposing a new priority data category. We think that all the data, the formats that are out there, patient summaries, prescriptions, discharge report, lab reports, imaging reports are dead. They are dead because they are data about things that happened. And there's the big question, so what? So what we are proposing, and this came from Denmark actually, that's where I was, is the idea of a care plan as a dynamic entity. So I am diagnosed, the question that I asked earlier, I'm diagnosed with condition X. So what do I do now? What are the 10 things that I need to do? That's a care plan. And then you go with your physician and you put health goals as well. You know, if I am diagnosed with hypertension, maybe I have a goal to lose 10 kilos, yeah? And maybe I need to test again for my cholesterol levels in 3 months. And maybe I need to take statins. So this is a care plan. And the Danes are saying that a care plan is a right of a patient. And why is this a secondary use question? Because there is something called a screening program. And you probably know what a screening program is, yeah? You find which people have a certain condition, like pre-diabetes, yeah? And then, after you find that, then you give them a care plan, which is their right by the health system. It's the right to care. And then you take the role of the policymaker or the health system. And you are saying, right now, so I gave this care plan to 1 million people. How much did that cost? What was the effect in the health of population? Because I'd like to end, and I'm sorry if I took too long, with that the EHDS is about making Europe healthier, making Europe more innovative. And we shouldn't lose sight of this important goal. And that's not a question of primary use. It's a question holistic, systemic, about the health system as a whole, and how we get those low-hanging fruits as early as 2026. Thank you.
Okay, so now I'll move to an open question, and if anybody has a passion, please go ahead. So, one thing I've been wondering, first of all, we have the problems of arriving at a format that works, right? If we do this, and we do it on a European level, how will it evolve after that? What will be the sources of innovation? And how will we avoid a rigid, fixed system that will not adapt to future needs? This is something I'm not a healthcare economist, but I find it difficult to conceive how future evolutions will occur, etc. Does anybody have any thoughts on that?
I can chip in with one or two things. So, for example, in Expand DH, which was a coordination support action, one of our mentions were, and it's produced a deliverable, was to already start looking at new data domains, or as we call them, data priority categories is the name in the law. We used to call them domains of the format when it was written as a recommendation from the Commission. And at that case, we wrote about, for example, telehealth reports. Because in telemedicine and telemonitoring, you produce a lot of data, needs to be integrated into electronic health record systems, and that's one domain. But other domains, and Catherine mentioned care plans, could be another domain, and that's definitely a big discussion, because that would touch more on how we care, and we care in very different ways across Europe. So that itself is almost the category of categories, because for example, another thing we found in sorts of innovation was that although from a sort of legal technical, we come up with what we call a discharge report, best, in 1 year time we will have an implementing act telling Europe and the world, and I will go into the world in a second, what we understand as a format of a document that is machine readable and human readable for a discharge report, right? Or a report of someone that stayed in the hospital. But as early as Expand, and we continue to do that work now in other projects, we found that depending on the medical specialty, the content is very different. Of course, all medical specialties agree that diagnoses are important. But when you talk with, for example, cardiologists, they will stress that they need certain items in the discharge letter. Oncologists will want you to put their Ann Arbor classification if the patient has enough data for a preliminary TMN classification, and so on. Every specialty is starting to discuss at the European level guidelines on reporting because of real-world evidence, because of real-world data and research in their medical society. So one of my visions, and we started that already, is to start asking about the discharge report as a technical clinical standard. And I think that's the source of innovation. If you plug this legal technical document to the needs of, for example, clinicians, because those needs are evolving with medical science, you will have some domains. I give you a simple example. As of now, we don't include a video as part of a discharge letter. Culturally, right? I mean, we write a letter in paper or we write in a PDF. We don't normally embed a video. But for a gastroenterologist, if he was one in the room here, he might tell you that actually, you know what? That little part of the endoscopy, I want it in the discharge report. So suddenly, we start talking about ECGs, EKGs, and all the medical technology. So the discharge letter can actually be an evolving domain. This is another source of it. And then to conclude, another thing that is a big passion for me, because I love to travel, this is my time now, that Catherine took like 10 minutes, which is, and she's helping me on this as well, don't worry, is the global EHR, or global health record. I am now dropping the electronic part, because I don't think you need to explain to anyone that a global health record will need to be electronic. Why am I talking to you about this? When we start talking to non-EU countries about what we are doing, they start asking questions. Two types of questions. Can we have it? So for example, next month I have a two-day workshop in London only on third countries, assertion to the European Health Data Space. Countries are already asking. I have a Chinese student now in Portugal in our group. She wants to look at how can China one day maybe exchange data with the European Health Data Space. Can you believe that? It's going to take a long of time. Legal, technical is not a big issue, huh? But legal and culturally and societally, maybe it will take some time. The second type of question is, but we here in Korea have another domain. We here in Hong Kong have traditional Chinese medicine data. We here in Brazil have data from the, the Amazons and other types of cultures. Are you considering that type of data? Are you considering this type of service? So when we expose our amazing idea and our amazing project, which is the European Health Data Space, primary, secondary, or circular use, as I call it, I can go into that if we have time, to others, to non-Europeans, they bring their own innovations and ideas to us. We don't even need to do much. And so I don't think we will get stuck. For sure, we don't get stuck. The final thing was, and Alberto mentioned, in the beginning of these discussions, some people said, so are we going to switch off this work that Martin is doing on connecting with the voluntary connections of the My Health at EU? Is that going to stop now that we have the regulation? And there was maybe 1 year of like, we stop it, we build something new, and then the conclusion was very simple. This is the basis. Because as soon as 17 and then 20 and then 27 countries share data voluntarily, they're more ready to share it compulsory. So we build on top of the innovation, because then we get more trust. And trust is the heart and energy of innovation. So I think once we have stabilized these 5 domains, you will start seeing innovation even in the mix of the domains. You take a bit of the patient summary, take a bit of a discharge report, and you build a new type of service. Like Catherine and XShare, just to reemphasize, I don't know if people got it, what they demonstrated here in Brussels 2 years ago already was that with my patient summary, I could go and try to find a clinical trial out there. So I would upload my data and some sort of software that was built, in this case by a startup, I don't know, from France, I believe, right? So there's new energy, also new companies popping up with new services, and that's where the innovation will come. Startups on Fire is something we're also going to put on the floor to promote innovation.
It's interesting, it's funny, actually, but it's also concerned me a lot that we have countries, further countries outside Europe, that are willing to test with the format, to experiment a bit, and we still lack awareness at the domestic level. So we have Chinese students, etc., willing to test something right now, to implement things, to exchange things. And the lack of awareness at the domestic level is still there, as I was trying to explain before. We should carefully think about this and try to propose a remediation, let's say.
Okay, now I'm going to move on to one of the final areas. The difference between the Commission guiding and enforcing implementation. What is the position of the member states? I know you can't speak for all member states, of course, but what is the position of your member state, Monica? Are you happy with how things are foreseen at the moment?
Actually,
Please use
yeah.
the...
Actually, in my view, the Commission's role should be more architectural and coordinating, and rather than micromanagerial, yeah. And it should like define common frameworks and direction, yeah. Develop testing and certification environments, yeah, for the all member states. Well, I mean, not all member states, but Europe level for all. And ensure alignments between HDS, EHDS, and My Health at EU. And at the same time, the implementation must remain flexible towards national systems and national platforms. Yeah. Otherwise, there is a risk of creating a harmonized solution that is difficult to use in real clinical practice. I think that's maybe some. Catherine can add something. Yeah.
I can add something here, and I think this is actually a question that I asked you where we are preparing. And the question I asked Monica was, do you think that this process, the comitology process with EHDS, is actually building trust among the member states? And Monica answered me in a very interesting way that kind of expanded my horizon. She said that this has started actually a while ago with My Health at EU, where by working together as country A and country B exchanging data, we started building trust in the comparative infrastructure. What I would like to add, though, there is that we have seen also an acceleration in Europe of the digitization and the digital transformation of health systems. Because with this environment, national programs have the opportunity to look at the other countries, to look at the other member states, and maybe in some way feel jealous. And say, wait, why is the Netherlands doing that and we in Belgium aren't doing anything? We will be 3 infrastructure instead of 1, yeah? So, yes, there is a process, and of course this is a culture-changing process, and never forget culture in anything you do, whichever your space is. Technical or legal, culture matters. And there is a major culture change that is happening these days in Europe.
Please, by all means.
So my position is very, very different on this one. A few years ago, I was invited to write a report for the European Parliament, so this is public position, about the usage of data in the COVID. So this was a report commissioned in October 2020, and the question was very simple: is Europe doing as well as it could with the data available, and what would be the policy alternatives? That was when we were discussing the beginning of the European health data space, and I asked, and I wrote, we should have a European health data agency. We have a medicines agency with a staff of 1,000 people, and that is why we have a common policy for medicines, an amazing, worldwide, competitive policy that competes with the FDA. And even against FDA, we're not there yet. We're not as fast as FDA in approving medicines. We're not as fast, definitely, at approving medical devices. And we're far from it at approving AI algorithms for care. But we have something, okay? Then we disputed when it came out of London. Everyone wanted it. And yet we were not able to agree to establish 200 people, 300 people agency that could actually be virtual. It doesn't even have to have a physical office that makes that city a little bit richer. No, it can be a virtual office. We didn't manage to agree. And where I'm coming from is where many years ago, the French colleagues, when I was the co-chair of the HELT network, they were very jealous about the Portuguese dynamics. You know, why are you going so fast and all of this? And I said, I have 600 IT staff in my company. I have a budget for a country of 10 million. I have a budget of 70 million euros for digital health. This is why we are capable of doing things fast. I have an IT team just on standards and interoperability that has 10 people. I even lended one to Santé, Licinio Mano, a very nice guy, stayed here in the commission for a few years and now he's back to Portugal. My point is, we need scale, we need muscle. How can we ever conceptualize this European health data space with 27, and with all due respect, small little agencies? Because they're small. Maybe they're big for our standards, but when we look at the challenge, we look at things like the size of the CDC in the US, and you know, these are gigantic things, and that's where expertise lies. For us to have, for example, 10 European-level experts on data curation, 10 European-level experts on SNOMED, 10 European high-level experts on health-specific cybersecurity in transactions, just cybersecurity of messaging, we have to have them somewhere. Can be virtual, but you know, a centralized budget. So I think these are not incompatible. That's what I want to say. I think the Commission should have an important role, but I think we should move, not the Commission and DG Santé, we should push to get at least something like ERA, which is a virtual new agency that came out of the COVID time. It's not as clear as EMA, that has its own building, its own bylaws, its own rules, but we need to have something like that. Maybe it's too soon, maybe in 5 years, 10 years, I understand, but I think without that engine, we will not be competitive against the giants, and the giants are very clearly China, India, US, and we need to be aware of that. You want to add something? No.
Okay, a final question from me, and then I will go to the audience. From the perspective of secondary use, for me, I was quite disappointed that there were not enough carrots and sticks in the proposal. For example, I know it's a bit controversial. I thought that there could have been room, for example, in allowing profit in data access fees, etc., to incentivize participation. And then in terms of enforcement, I felt that there was the enforcement tool for the Commission is just too blunt. It's not going to be useful. What is the picture in primary use in this area? Are there sufficient carrots and sticks to push member states forward, to push individual health agencies forward, etc.? Or are we looking at a similar position where we're hoping for the best in terms of, realistically, in terms of member states pushing their respective entities forward?
Oh, okay, in primary use, I think there is sticks. There is sticks, but I think that we all should understand that European Commission pushes us for the, to build the trust between the primary use of data, yeah, to build the trust, because even in my small country, where are only 3 million people in Lithuania, even if patient goes to one hospital and then deciding or we're dispatching GP, for example, dispatching him to another hospital, that another hospital, he against doing the same results. I mean that he's diagnosing again the patient. It means that he's not trusting the other hospital's data, So I think the main idea of the HDS, it's to trust, to have a distrust, you know, and I think in economical perspective, that will be also saving the money for that, not to do that. I think that's my view, and yeah.
Want to add?
I can add just with numbers. So, for example, in the case of Portugal, when we started doing the national sharing of labs and imaging and other exams, we had to say how much it was, right, for the budget to be given to the agency. And we estimated a savings of just 5% reduction. And this was based on publications that show you that there's maybe 10, sometimes as much as 15% of duplication. So sometimes a diabetic patient will have maybe 5 or 6 glycated hemoglobins done in a year, when mathematically you only need 4 of them, right? Mathematically, because they are valued 120 days. So you could definitely cover well a patient with just 4. So based on these high-level numbers, we said, you know, this is how much the country is spending on medicine, on exams, and we knew that because we pay, right? So, and then we said, so this is how much money we need for the project, 2 or 3 million per year for the next few years, and you'll get the return. And we got the project, and it's been implemented. So the court, in this case in Portuguese, the Court of Accounts, that evaluates how the government spends money, actually more than once asked the digital agency and the government, in the name of the Ministry of Health, to detailedly explain how much the country spent and how much the country benefited. For example, e-prescription. Actually, the Commission used some of that data because it's not easy to find. What I'm saying is the European Court can actually do this. It can actually ask, you know, why are you not implementing a tool that would save you money? And so I think I agree with you. I mean, I would like to see a little bit more. For me, one of my sad moments about the regulation is actually the drop of the original Article 8, which was about cross-border telehealth, because that was the door to cross-border care, true care integration, mutual recognition of practicing physicians and things like that. That was way too early, okay? But it will come. And I think that the same is to financial incentives. I think we were all afraid it would never pass in the parliament. So I think that was wise not to put it there. But I agree with you. We need to put more money into the data, and the data needs money, and money comes from data. And we need to live well with this relationship. Europeans, we don't. US people are a little bit more prepared. The carrot part, the stick part, I don't know. I mean, I give you a few, 2 tips that I think everyone will understand. National level, e-prescription, countrywide, my country. 1 year. We had a law, it passed, and it said, if you do not make it electronic, you do not dispense. This is the same in Greece and everywhere. A transactional system, you can force it down people's throat, because they have no way of escaping. They need the service, the digital service. No, and they need the medicine in this case. But the data sharing, so for me to share with you the data so that your clinical decision is a little bit better, requires you to want to read my data. What we found in Portugal is once we created the national data sharing platform, we couldn't order the doctors, please go and use it. It was there. We monitored, we created indicators every month, and we monitored how often they would access it. They all could access it, and yet the access levels in some emergency rooms was 0.5%. In others, 20%. So it takes a lot of years for people to trust the data of the other people. Because medicine, we were trained to learn only on our own little campus, believe on our own little documents.
Excellent. Given that it's been a long day, I propose we go to the audience for any questions before we wrap up.
Hello.
Surprise.
I just have a question about, I didn't hear anything about doctors and what's the role of the doctor, and also of the deontological associations of the doctors. I'm a lawyer, and if you want anything to get done, you go to the bar, and the bar will make sure that it gets done for all the lawyers. And so I was surprised that that is not some sort of mechanism that you're using for, I don't know, awareness, consistency, data access, whatnot. So I'm more interested in, those two aspects, the doctor and the deontological associations.
Maybe I can take this one. Yeah. I can answer in two ways. I can answer, you are a lawyer, and I would like to, I can give you one answer which says the HELT was very careful not to impose additional requirements to health systems of the national governments. That's my answer one. Now, when we are proposing in XR a new priority data category that is called care plans, then this is all about doctors, because this is all about workflows, how the doctors work. And yes, it is true that some doctors don't like to follow clinical guidelines, but care plans are derived from guidelines, and we have a partnership also with WHO, which has developed this new program of smart guidelines, so that we have a method that we go from the official evidence-based clinical guidelines with the engagement, of course, of doctor boards. It happens differently in different member states to create a care plan template, so to speak, for specific diseases like heart failure or hypertension, you name it. And then there is an execution phase. And then the value of secondary use, because I understand many of you are in secondary use, is that you can assess this policy. You can see whether you saved money or not. And this is about care. It is not about how much drugs you used, which is always my kind of reservation when we talk about prescription, yeah?
Well, being a doctor myself, let me answer you. Doctors definitely are not like lawyers. So we don't pay much attention to our associations. We often we are forced to pay the fees in most countries, otherwise we get out of license, but that's about it. But however, this is changing. And there's two things that are changing in the doctors' societies around Europe. One is the emergence of what I would call digital doctors, so young doctors that are working with digital people, startups, things like that. So there's a new generation in town. There's another thing that is changing is that not just in my country, but in others, the doctors' associations are creating what we call competencies in digital health. So not a medical specialty. The US has a specialty itself in medical informatics. But in Europe, we don't see that trend. What we do see is like you have emergency medicine or you have management as a competency. So on top of your medical specialty as an orthopedic surgeon or whatever, you can take additional study and you have the recognition. So this is now starting in many countries, one such competency, it's called like that, in digital health. So I think it's by that means that we will get them on board. And then, as Catherine was saying, the guidelines in different ways and shapes, especially when they participate in the writing and the balloting of guidelines. We see this in communities like cardiologists, oncologists. They're very adherent to their own rules because they built their own rules. So it's a different beast, definitely, from the lawyers.
Any further questions? No.
Don't be shy. Can I ask a question to the audience?
Yes, please.
Has any one of you ever downloaded your health data from your hospital? Okay, see? See? How many of you believe you have data in another institution that has not yet reached or has been integrated into your main institution? You left data around Europe, and it's there waiting to one day be reconciliated with your original sort of file.
May I ask also a question? How did you use the data you downloaded?
Yeah, there's more hands raised.
I shared my data with somebody in Italy who gave me additional information, so that I did that. But I'll just add in one thing, maybe you can comment. I think that sometimes doctors, I don't know, this is maybe like technical glitches, they don't, I've had data which they needed to unfreeze or unlock, and they need to do something, and I find that sometimes there's a bit of a reticence of the doctor themselves to, with regard to this having access. So for me, as a patient, I've actually found that the doctor's a bit of a like a door, not a door, like a closed door, okay? So I don't know if you've seen that.
Totally, totally correct. And I would like to add something that is different in different health systems. In some health systems, the doctors act as gatekeepers to lab results. So unless your doctor unfreezes, opens the door, you cannot get access to your data. And sometimes it doesn't. It is totally like stupid, like a pregnancy test, for instance. Unless your doctor signs off, you cannot know officially if you're pregnant or not. I mean, yes, there are stupidities there. But I'd like to ask also the other.
May I jump in? So I also have an answer to your question. As a foreigner here, I download for example, my blood test, and then I ask AI to analyze for me, because as a foreigner, I speak English with my doctor, but normally the explanation for me is not really sufficient, so I need to get more answers from AI.
Yeah. Me too.
No, for me it was quite simple, because I had to do the X-ray, and actually this was the first time I had this, that I actually saw the interoperability in action. I was like, wow, this is so great. I also come from another country which is technically the best in terms of, one of the best in digital healthcare, from Poland. So I was like, and I didn't experience that here. I experienced in Belgium that the doctor told me to do the X-ray, and then this doctor, because I wanted to send the doctor, I don't know, via WhatsApp or something. I shouldn't do that, but I wanted. I was like, do you want to see my X-ray because it's ready? He's like, no. I could see that in the system. I was like, wow, this works. But then when I wanted to show it to a physiotherapist, for example, then I had to download it, and then I showed it to the physiotherapist, because the systems are not connected to that scale yet. So, but in general, somehow it worked, but at some points it didn't. So
this is what we are trying to do with XR, and this is the magic of it, because as I was trying to explain, this is a culture change that we all collectively are making happen. And I know in some countries you will not be able to get your data immediately. In some countries you will get them immediately, but in the end, you can get insights from your data. You can do more things because you are part of it. And this is the magic of EHDS, and this is why it is something that other countries are looking out for. Thank you.
So we have heard at least 3 different examples where the health data are flowing using the patient, the citizen, as a gateway. So we are not talking about the government-to-government transaction. We are empowering the patient. Catherine mentioned XShare. I could mention the UDI wallet as well. So different flavors, but the message is the same. Citizen as a gateway, as a proxy, if we can call it, to support an alternative way to promote interoperability and to exchange data. I believe this is one of the possible way forward, indeed.
We have another hand.
I would just, may I just give my own personal experience, because it's quite interesting actually, relevant to what we were talking about. I have a severe milk allergy, as the people I ate with last night had to hear over and over again. And often have a problem when I travel to a country where I don't speak the language and I consume milk by accident. I have been to accident and emergency in about 4 or 5 European countries. I've had to explain in the middle of an anaphylactic attack that I have a severe milk allergy, which is not a very nice thing. When people, there is a language issue also, no interoperability. And then when I come back to Belgium, where I live, my home institutions have no knowledge of any of this. It is never known. So I am actually one of those few tiny percent who has to use. The
EHDS allows you to actually enter data into your electronic health record. It mandates that. So I hope that in the future you will be able to enter this information yourself if the connectivity is not there. But
no, I just wanted to give a personal example on the fact that patient empowerment is very important and the trust of the patients in sharing their data, because I have a rare disease and 10 years ago I switched from hospital for the follow-up, and the first thing the doctor said, like, are you aware yourself what is in your patient file? And I was like, no, because it was 10 years ago and it was very difficult to access the information. And the first thing she did is that she printed me all the summaries of the medical appointments I had, and I was like, oh wow, I'm allowed as a patient to know the medical terms behind the disease, and since then I've been much more involved and much more, like, I don't know, self-aware, and I see the doctors more as a companion or like an added value to knowing myself also what is going on.
so have you looked at clinical trials that are related to your condition? That's probably the next step.
Okay, we'll have one more and then we're going to have to wrap up, and I suggest we take conversations bilateral after that.
I just wanted to mention that in the beginning you were concerned that primary use was not exciting for this audience. You see, the power of discussing primary use is that every one of us has a story. This is how we're going to get it through. And I call this, and it's written, and we're using this concept in other projects, health data activism. It's not enough to write the rights in the law. You have to have an activist movement. People have to stand up and fight, literally, and even legally. Because most countries' jurisdictions, they have local laws. You might say, oh, but regulation supersedes the local law. We all know that from the legal world, but in the real world, they will not press the button. They will not open the data for you because they think in the way that their law of their country was ingrained to them many, many years ago. So I want to invite everyone to think about health data activism, and next year in the panels, maybe have a panel on health data activism and the role of citizen science and citizen for promotion of the European health data space.
Okay, I would like to thank the panelists very much, in particular for waiting for this end of day panel, which is always the most trying, the most tiring, and yes, all of that. Thank you very much. It's very much appreciated. Thank you to our audience who also braved this and resisted the urge to go out and drink a nice beer or coffee in the Brussels sun. It's not sunny anymore. Okay, thank you very much. It's much appreciated. It's been a pleasure. We're going to wrap up now. I am slated to give some closing remarks, but I'm not going to do that. I want to leave also. So please keep in touch. It's great to keep this community going, this HELT community. Get in touch with us if you have ideas for future collaboration in this type of event, including for ideas for the symposium next year. And to remind you, we also have a monthly HELT Talk series that we host at the university. These are more small-scale events related around a single issue. If you want to do this with us, if you want to engage in this, please contact us. We'd be delighted to hear from you. A final thank you to my colleagues at the VUB, many of them standing there at the back. Thank you for your hard work in helping me realize today. It's much appreciated. You all worked heroically. I'm very grateful. Thank you very much.